Uh, please, I'm in a webinar, please. Uh, Good evening, everyone. I'm Dr. Neelabh this side. Today, we will discuss about the different problems of the knee joint and its treatment. As you know, knee has got many parts. Knee, if we talk about the joint, then we divide into three joints. The tibio femoral joint, which we again divide into two parts, and then the patellofemoral joint. So there are three joints. We say three bones make tibia, femur, as well as patella in the front. They are all attached with the soft tissues. Soft tissues are again divided into two parts. One is the ligaments which attach them, like the on the side is the medial collateral ligament, lateral collateral ligament. Then from the front and the back, there is an anterior cruciate ligament, and there is a posterior cruciate ligament. So these are four ligaments. If you see the model here, I'll show you the model. This is the femur, this is the tibia. I'm sorry, this is the model of the knee replacement. So there are the ligaments on the sides, medial collateral and lateral collateral ligament. As this is a model of knee replacement, so anterior cruciate ligament and posterior cruciate ligament is not visible. So now from these joints, when we have talked about the ligaments, we have talked about the bone. There are other parts also, like we have got the joint capsule, which encompasses the whole joint. And from there, inside that is the synovium. Synovium, which is a layer which forms the synovial fluid, which keeps the joint lubricated. At the same time, just below the knee joint, where the sartorius, semimembranous tendinosus muscles are attached, they are they are bursa, which is known as pes anserinus bursitis. Bursa. So we have pes anserinus bursa. We have got the synovium. We have got the joint capsule. We have got the ligaments, and at the same time we have got the bones, forming three joints. So if the patient complains of pain, we have to find out which are the regions. Region means area from where the pain is coming. Sometimes it comes from the posterior backside of the knee. From the backside, there are muscles attached like gastrocnemius, etc. So where the gastrocnemius is attached, there are again bursa over there. Bursa is nothing but the a small pouch in which the fluid is there, bursal fluid we call it, which gets inflamed sometimes. So even that causes pain. So once the patient comes and tells us that there is pain in the knee joint, then we have to find out which part of the knee joint. Number one, when does the pain occur? How does the pain occur? How is it increased? How is it relieved? Now the patient who complains of pain in the knee joint, that pain may come from the spine, from the that is on the back, from your backbone. There's a disc, etc., which causes the pain. Then it can come from the hip joint, which can radiate to the knee joint, and then it can come from the structures around the knee joint, like the bursa, like the muscles, which gets inflamed, and all these things. And at the same time, the pain may be from the knee joint itself. So we have to find out. So whenever you are examining for the knee, you must examine the spine and as well as uh, hip joint along with the knee. That is very important. At the same time, if there is a problem in the foot, a patient has got pes planus, valgus, etc., that again puts abnormal pressure on the knee joint, and that may cause pain in the knee joint. Now, when we come on the history part, so history you have to ask about how did the pain start. Like if somebody has come from the prolonged journey while sitting in the car, then the most probable cause is either synovitis or inflammation of the patellofemoral joint. Uh, is the pain constant or is it increasing along with the time? When is the pain most? Whether it is during the day, in the morning when the patient gets up from the bed, or whether it is in the evening, or whether it is when he is working. How is the pain relieved? Whether the pain is relieved by sitting or not, that is very important to know. Because when we talk about the pain, we say that it may be mechanical, it may be inflammatory, and it may be infective. Then we have to ask about the swelling after the pain. Then we have to ask about whether there is a pain in other joints also or not. So you have to take a very elaborate history when you're talking about the history of any joint, including the knee joint. So it's not that whenever patient is coming for knee pain, he's just suffering from knee arthritis. No, knee arthritis is just one of the causes of the knee pain. No, mechanical pain can occur if there is a meniscal injury and all that. There is a packing which we call meniscus in between the femur and tibia. One on the inner side, which is known as the medial meniscus. One on the outer side, that is known as the lateral meniscus. There may be inflammatory. Inflammatory pain comes especially during the arthritic pain. During the arthritis, whether it is rheumatoid arthritis, whether it is ankylosing spondylosis, or any other cause, or whether it is infective. If whether there is a fever, there is a joint, this joint is swollen, red, inflamed, painful, and there may be degenerative. So all these are there when you are taking the history. You take the history of pain, you take the history of fever, you take the history of involvement of the other joints, you take the history about the swelling, and so many things. Now, once you have taken the history, the second thing comes the examination. Examination always starts when you make the patient walk, or rather you can assess the patient when he is entering your examination room, whether he is limping or not. If the patient is limping, then he has got pain in the knee joint, which is entalgic. A spine joint or on the outer side of the knee. Hip problem, again, patient will have different gait. And at the same time, when there is a knee involvement, the patient will have different gait. So once you are examining, the first thing you check is the gait. You make the patient stand also, you check for the Trendelenburg test also. Then comes the inspection part. During the inspection, as is common, you look for the swelling, you look for any redness, you look for any varicose vein, because even varicose vein causes a knee pain in some cases. Patient just has got varicosities, otherwise knee is all right. So after the inspection comes palpation. So in palpation, you check for the cross fluctuation, you check for the area of tenderness, you check for the movement, you check for the varus, you give varus and valgus strain, you check for MCL and lateral collateral ligament, whether they are intact or not. You check ACL and PCL by doing the Latchman's test as well as anterior and posterior drawer test. So these are specific tests which tells you about the area which is disease or which is causing the problem. Similarly, for meniscal injury, you check with the McMurray's test. McMurray's test tells you whether the meniscus is intact or not. But sometimes if there is a defect in articular cartilage, then the patient McMurray's test can be painful. So the patient will have pain or there will be no clicking and all, but in a particular moment, it will be very painful where the defect in articular cartilage comes in contact with other bone. So after that, you also check for correctness in movement, you check for the range of the movement. No examination of the knee joint is complete until unless you have checked the hip, you have checked the spine, you have done the straight leg raising test, you have checked for the foot. Once you have done all the tests, then you have come out with a provisional diagnosis. What can be the cause of the pain? Because if the patient, sometimes patient says that the patient he has got pain below the knee joint. There is a Pearson's bursitis, and he has been diagnosed as osteoarthritis of it. So you have to be very particular in the examination part. And once you finish your examination, You should be ready along with your differential diagnosis that what can be the causes. Then comes the investigation part. In investigation part, usually what I do, if there is inflammation or swelling, then I get the complete blood count test and ESR also checked. If I'm suspecting arthritis, if there's a swelling in the other joints also, then we check for rheumatoid factor, anti-CCP, NA profile also. If there's psoriasis, there's a skin lesions in the patient. Only then I check for HLA-B27. Otherwise, I don't. Or if the patient has got fused back or a sacroiliitis, only then check for HLA-B27. Otherwise, it is not so common. Once you have ruled out the arthritic conditions, you have ruled out the infection, then comes the metabolic causes. Metabolic causes is mandatory for me that I always get all my patients investigated for metabolic causes. I check for blood sugar, I check for uric acid, I check for KFT, I check for calcium, the thyroid, vitamin D, and as well as vitamin B12. X-ray is mandatory. That whenever you get the X-rays done, the patient doesn't have that much of pain. It should be a standing weight-bearing X-ray. In weight-bearing, we get both the knees on the one film. Both we get AP and lateral view done, and that tells us about whether there's a reduction in the joint space, whether there's a varus or valgus instability, and how is the patellofemoral joint. If you are suspecting that there's some problem in the patellofemoral joint, then we must get the skyline view done also to see whether patella is properly seated on the femoral condyle or not, or whether there's some lateral subluxation or whatever maybe the things. If you are suspecting that there is some cause like ACL tear or PCL tear or there's a meniscal tear, only then we go for MRI. MRI always tells us about these soft tissue injuries, whatever may be the injury. Similarly, if there's a history of trauma and there's a fracture, then we have to get a CT scan also done. So far about the investigation parts. And after investigation, we come on the treatment part. On treatment part, we have to treat so many conditions. If we let's talk one by one. If there's a infective condition, counts are high, ESR is high, then we have to get the synovial fluid aspirated and send it for culture and sensitivity. If it is negative and it is not responding to antibiotics and all, then you have to get the synovial biopsy also. Synovial biopsy is done in case of hemophilia, etc. They also affect the knee joint. Sometimes in hemophilia, when you do the synovial biopsy, you find that it's full of iron, hemosiderin iron. That gives it a black appearance. If you find something wrong in the metabolic process, then we have to treat that metabolic cause, whether it is thyroid or calcium vitamin D deficiency or whatever it is. Now, the treatment, as far as treatment part is concerned, the most important part is the non-medical treatment. If patient is obese, then we tell the patient to lose weight. That is very important because unless pressure is released on the knee joint, pain does not go away. Number one. Number two, we tell the patient not to squat, not to kneel, not to sit cross-legged. If the patient is not aged, then it is prevented temporarily. But if the patient is aged and there's an arthritic changes, then we tell that never ever do it. Then there are exercises, isometric quadriceps exercises, knee mobilization exercises, quadriceps strengthening exercises. These exercises help a lot. They are very important part of the treatment. If you are treating the degenerative disorder of the knee, which we call once we have changed the sitting habit, cross-legged, we have prevented a patient to sit cross-legged and not. Once we have taught the patient the exercises, once we have told the patient to reduce weight, then comes the physical therapy part where give the warm saline. I especially prefer warm saline fomentation to the patient, or we give some gel. A new gel has come which claims that once you apply the gel, glucosamine level in the synovium is at par with your oral tablets. That is again very important that you see whether the synovium is healthy or not. If everything is normal and patient is just arthritic, because that is the maximum part of the knee pain, especially in old age patient, then what should be the treatment? It all depends. The treatment varies from age to age. Like if a young patient, say 20, 30, if they come to us and complain about the pain in the knee joint, then we cannot think about the degenerative changes. We have to think about the metabolic causes, or we have to think about the inflammatory causes, or we have to think about the mechanical causes. If there is a meniscal injury or ACL patient is intact or not. If the patient comes in the age of 40s, so 40 to 60 gray zone, where we don't usually advise the knee replacements and all. But if a joint is bad, then we tell the patient to take to wear the brace for the knee alveolar brace. But in the head-on study, no difference has been found between the results of both the braces. The results are equally good in both the cases. Why hinge knee brace? Because in the hinge knee brace, approximately 30% of the weight is bypassed. So the pressure on the knee is 30% relieved if the patient is wearing it during the acute phase. It is only for the acute phase when the patient has a lot of pain. Once the pain is relieved, then I don't prefer that patient should wear the brace. Until there is a severe varus or valgus deformity, then to prevent the deformity to move forward, I gave either knee immobilizer brace or knee brace to maintain it in the deformity, how much it has come. If the patient is not willing for the surgery, deformity correction. Now comes the part, initially you also give some painkiller. I prefer to give either crocin or ultraset. Because in many conditions, especially in the old age, the patient does not go for the surgery, then the pain is there. And if you give NSAID like diclofenac, aceclofenac, etc., then they start taking their on their own. They will come, they'll show us once, twice, thrice, and then they'll keep on popping up the tablets at home. Ultimately, when they report back to us after say 2 years, 3 years, by the time they have got the renal problem, CKD. So I prefer to give plain and simple crocin pain relief, 650 milligram, and paracetamol 650 milligram, and or ultraset, or these stapendadol nasal spray. These are the three painkiller which is my favorite. Now, if we talk about the treatment part, can we treat the osteoarthritis? The result is very empirical, and in all the head-on study, including Vidar study, no benefit of any treatment has been found. But if the patient is having pain and he is say 40 years or 45 years, then naturally knee replacement is not advisable. We have to live with that condition for the next 10, 15 years or 20 years. Or due to some medical problem, patient is unfit for the surgery or patient is not willing for the surgery, then what should be the treatment? Physical part, physical therapy remains the same, lifestyle modification remains the same, analgesic remains the same. Whatever medicine like calcium, vitamin D, whatever we have started to treat the metabolic cause remains the same. Yes, one test is also very important. That is a DEXA bone densitometry, which I get it done in old age. And if the patient is severely osteoporotic, I treat the osteoporosis as well. And that is always helpful. Other things which we can give for the pain, especially if the patient is not willing for the surgery or unfit for the surgery. Number one is hyaluronic acid injection in the knee joint. The Molecular weight, the higher molecular weight it is, the better it is. Now there's an injection which comes where you have to give just one injection every 6 months. Uh, I always tell my patient that it is not for the pain. It is to prevent further damage. It will decrease the speed by which your knee is becoming bad. That is very important. Second thing is the oral medication. Oral medication, now a lot of medicines have come. My preference still goes with the collagen peptide. Collagen peptide with a glucosamine 1500 milligram, that is 10 gram of collagen peptide and 1500 milligram of glucosamine is my favorite combination. But at the same time, if you wish, you can give other things also. Like many people prefer to give dasarin, but now gradually dasarin has come in disrepute. So people are not preferring to give dasarin. Then there's a combination of glucosamine and chondroitin sulfate. Now undenatured collagen type 4 is also coming in 40 milligram tablets. I don't know much about the herbal preparations which are coming in the market, like rosehip extract, boswellia, mobilier. I don't know much about them. So my preferable treatment in a patient in which I cannot operate and the patient is having knee problem with the arthritic changes are the calcium, vitamin D, some analgesics, and collagen peptide with glucosamine combination. This is what I give. And if the patient agrees, I give the hyaluronic acid injection, which I repeat every 6 months or 1 year, whatever the patient ability is. If the patient is at the ripe age of surgery, say 60 plus, 60, 65 years of age, and if he has got the knee pain, especially for me, it's a rest pain. Rest pain is the best indication for surgery. Rest pain means that once the patient even is lying down on the bed, he is still having pain in the knee joint. So that is the, according to me, that is the one and the only and the best indication to advise surgery to the patient. Just as with mechanical pain, if he's weight bearing or when he's doing the prolonged standing, I'll try to find out the other reasons for the pain. I'll not advise him surgery for all these things. I'll check for the osteoporosis if the patient is osteoporotic. I'll check for calcium, vitamin D, thyroid, etc. I'll treat it. So for me, it's the main indication is only conservative. But the patient is not getting better with the conservative treatment. Number one, if the X-ray says that the knee is very arthritic and patient is willing for the surgery, then I'll advise the patient to undergo knee replacement. Now there are many myths about the knee replacement. Many patient comes and tells me that one of my neighbor has got it done and is bedridden, he is not able to walk even now and whatnot. If they will ask me if whatever I'm working, if I'll be not able to, I'll be unable to even walk after that. I always tell the patient that once I do the surgery, the very next day I make the patient walk. Rather, if I'm operating in the morning, I make the patient stand in the evening. Walking is very important. After one day, I make the patient climb up and down the stairs. Just after 1 or 2 days. So when they send the patient home, I always encourage them that every hour you go out, you walk. Yes, you will have walker, but along with the walker, you walk for 5 minutes, 10 minutes. Go to the toilet in your house. Sit on the dining table and then have your meal. If you have a balcony, then go and sit in the balcony. Don't remain bedridden. And walker is there just for 2 weeks. After 2 weeks, we tell the patient to leave the walker. If the patient is having pain, then I give a stick for another 10 days, 10 to 14 days. And then I tell the patient to leave the stick also. If patient does not have any pain, then I don't even give a stick. I make the patient walk. So for me, to advise knee replacement, the first criteria is that it should be in grade 3 or grade 4 changes in the knee joint on X-rays in the knee joint. Number 2, the patient must be having the rest pain, or a pain which is not being getting relieved by any other medication. If the patient is young, then I'll search for the other cause. Why is the pain not going away? If the patient is old age and the knee is bad, then I'll advise him to go for the surgery. So at different age, by different cause, by different history, treatment always varies from one patient to another patient. So it all depends whatever the patient is telling and is suffering from. If there is any question, I invite the people to ask me any question if they want to ask. Or should I continue speaking more on this topic? Are you people able to listen, hear me? Hello? So let me continue speaking. If the patient is suffering from inflammatory conditions like rheumatoid arthritis, then of course the first line of treatment is to control rheumatoid arthritis progression of the disease. So initially, I believe is still in 4 drugs: methotrexate, sulfasalazine, uh, hydroxychloroquine, leflunomide. Now tofacitinib has come. So just in a few patients, I have started on tofacitinib. It's a very good drug. If after that, if ESR, CRP has started settling down, but the pain is not going and the knee is bad, if there is a lot of deformity, then I advise the patient to go for surgery. If the joint is not so bad, but that there is a lot of synovitis, then I tell the patient to go for arthroscopic synovectomy. Many of the patients do well with the arthroscopic synovectomy and demand medicines for another 10 years, 15 years, till they require the joint replacements. So in any arthritis, it's very important that you should treat the arthritis first. Whatever the metabolic causes are, you have to treat that metabolic causes first before you jump on the surgery. Meniscal tear, if there is a simple posterior horn tear, I treat the patient conservatively. I don't say the patient to go for the surgery, but if there is a large radial tear in the body, or if there is a bucket handle tear, that is the indication for me to tell the patient to undergo surgery. Now it depends on the age of the patient. What is the age of the patient? If the patient is quite young, then I tell the patient to go for meniscal repairs. The patient is already old age, then it's a partial meniscectomy is always gives a very satisfactory result. And we tell the patient that he might later on require knee replacement. If there's a ACL tear or PCL tear or avulsion of MCL or LCL, then LCL is repaired, ACL and PCL are reconstructed. We reconstruct the ACL and we reconstruct the PCL, depending upon the condition it is. Now remains the infective condition. So in infective condition, because it's a superficial joint, so we just aspirate the joint out, we aspirate the fluid, we send it for culture, and we start on, I prefer to start on cefuroxime and amikacin combination. And once the report comes, then I change the antibiotic according to the report, whatever report comes. For me, the protocol is to give 2 weeks of IV antibiotics and 4 weeks of oral medication, 6 weeks. At the same time, I give the patient knee immobilizer press so that there is not much of movement in the knee joint. Depending upon his situation, if the disease is not settling down, then I prefer to do arthroscopic debridement of the joint. Even arthroscopic debridement of the joint decreases the tissue load, and that makes the drugs available in the joint. If there is a metabolic cause, then you have to find out, because many of the times metabolic causes mimics arthritis as well. Once you get the patient tested, you will find that there is a vitamin D deficiency or calcium deficiency or B12 deficiency, or patient is having borderline thyroid problem or borderline diabetes. So you have to treat all these conditions. This is very important. If initially, if there's some metabolic cause and there's some grade 2, grade 3 changes in the knee joint, I treat the patient conservatively just on the analgesics and I treat the metabolic causes. If patient is not relieved, then I start treating him as a patient of arthritis. So I believe I have, in half an hour, I've covered most of the part. If there's anything, just let me know. Hello.
Yeah, thank you so much, doctor, for joining this webinar, sir.